So thank you very much, everyone, for joining. This is the Academy of Nutritional Medicine's webinar with Dr. Armin Schwarzbach on the growing evidence behind the connection between infections and cancer. We're delighted to have him here with us. Very, very important and special subject. Dr. Schwarzbach, who I'm sure you all know, is the founder and medical director at Armin Labs, Augsburg. And as well as being a medical doctor, he's also a specialist in laboratory medicine with over 3 decades of experience in clinical medicine and lab testing. As well as being a clinician for many years, Dr. Schwarzbach has tested coming on to 500,000 patients for Lyme disease, co-infections, viruses, and recently SARS-CoV-2, COVID-19. He specializes in laboratory medicine, in infectology, microbiology, immunology, hematology, endocrinology, and has also worked in oncology. So, Dr. Schwarzbach, thank you very much indeed. Very much looking forward to this. We will be answering questions at the end for 15 minutes, so please put any questions you have in either the chat or the Q&A. Over to you, Dr. Schwarzbach. Thank you.
Thank you very much, Gillian. Thank you very much to all coming to my presentation. We will do 2 different parts because there's so much growing evidence behind the connection between infections and cancer. I started with that some years ago at the 𝐕𝐈𝐃𝐄𝐈𝐒 conference in America. I think it's 6-7 years ago we started with these chapters, and I remember back when we had just the little slides and information about that, and it was to me also a very brand new field where I said to myself, oh, maybe I missed something in my career. I worked oncology 2 years. I did chemotherapies, grading, staging, breast cancer, pulmonary cancer, prostate cancer. I worked leukemia that time, and I never have thought about that possible connection. So, sorry, the next slide is coming. We have a growing research suggesting that a number of viruses, as Gillian mentioned, bacteria and parasites cause cancer in humans. This is a paper from 2012. It said that it's estimated about 20% of human cancer cases worldwide can be caused by infection with bacteria, parasites, or viruses. So this is not a new thing. Maybe my career started internal medicine early 90s. 30 years ago, that was a different situation, but it happened also during the last 20, 30 years a lot. So the question is, which cancers have pathogens been associated with? So I don't want to say that the pathogens are the reason for it. I want to say we have associations. This is very important to say, not to conflict with any guidelines from oncologists or things we are doing with chemotherapies. I did a lot of chemotherapies myself according guidelines that so, but we need to keep an eye on that. And I say always, you could have lice and flea, you could have both. You could have an infection, but you could have also cancer. So it's the same with the Lyme disease story. You could have Lyme disease, but you could have also multiple sclerosis. So one condition is not excluding the other. The question, if it would be really the reason for it, you could see if cancer might be reversible, if you have a chance also to get rid of your tumor cells, if there's an option for the patient, then you could say, oh, okay, I have done my work with infections, and the infections maybe were underlying, and the patient is better now, and the cancer is in a regression, which is really good, not a progression. But I want to talk about associations. I think it's a good way, not conflicting with oncologists. Part 1, we will talk today about breast cancer, blood cancers, monoclonal gammopathies, glioblastoma, and prostate cancer. In the second part, we will do a different webinar some weeks in the future. We will talk about lung, pulmonary cancer, colorectal, gastric, esophageal cancer, and cervical cancer. I think we can do a longer list of that. So let's see what we could add in the part 2, because you will see a lot of information. You will get a lot of evidence-based medicine slides. So we cannot overload you with this information. So the first is breast cancer. What cancers have pathogens been associated with? Also the word association. I want to bring that in the focus. Association, not say the reason for it, or reasoning it, maybe or not. Professor 𝐓𝐇𝐈𝐒, really a good professor. I like her work for years. We know each other for 15 years now. She did basic research, fantastic work in that, not just for Lyme, persistiforms, biofilms, and so on, different therapy strategies. She gave us some weeks ago, or not 2 weeks ago, it was incredible insights into the possible links between Borrelia burgdorferi and breast cancer. And I was really astonished myself how, from her point of view, she's a basic researcher. She's not a clinician like me, not a medical doctor, but how close we are together in our points of view. And this is really good that there's a lot of basic research done. My part is more, I'm a clinician, I'm a laboratory doctor, medical doctor. So I have also some own patients where I keep an eye on that. And I have my oncology experience. I could do grading, staging with tumor marker antigens, all of that. I know how it works, and I'm a clinician. I'm sitting in front of a patient. Many of you are sitting in front of the patients being therapists, and you need to think about the option. Could there be a link between infections and, as an example, breast cancer? In a British journal, 2011, so 11 years ago, the Epstein-Barr virus, EBV, was discussed as a marker of biological aggressiveness in breast cancer. In this study, they found in 33.2% EBV positive breast cancers, they tended to a more aggressive phenotype, also more frequently estrogen receptor negative with a high histological grade. And also the thymidine kinase, which could be also used as a proliferation marker in breast cancer or cancer totally. They found really also an overexpression in this group with this EBV, Epstein-Barr virus infected breast cancer patients. The conclusion of this study was that it provided evidence for EBV associated, always the word associated we need to use there, breast cancer undergoing distinct carcinogenic processes with more aggression, more aggressive features. What does it mean? If you have aggression, like SARS-CoV-2 has also a virulence, it could be more or less aggressive to you in this model. So you could really get rapid progression of your cancer cells. And this also I want to discuss that maybe if the cancer is too aggressive, an infection maybe is too aggressive, it's difficult to stop it. It's also difficult to make it reversible and to maybe to heal a patient or to help a patient. So this is for all infections, we know. So I think sometimes we come simply too late in diagnosing infections parallel as a possible association with cancer. In 2012, a study showed a statistical association of Epstein-Barr virus with increased breast cancer carcinoma risk after analysis of 1,535 cases. This is a lot. So also this meta-analysis showed a really significant association, again the word, with Epstein-Barr virus infection. The question is now which symptoms are doing Epstein-Barr virus infections, which symptoms are really cancer symptoms. You know, when I worked in this field, we had the A and B symptoms to evaluate, and we know that also cancer, also breast cancer, does a lot of fatigue, myalgic encephalomyelitis. But we know also nowadays that Epstein-Barr virus is highly associated with long COVID, post-COVID, and could do also the same thing with this myalgic encephalomyelitis. Maybe part of the symptom could be in parallel symptom of the Epstein-Barr virus, which might be active or not active. Question is, how can you diagnose that? We come later to a slide where we will see which diagnostic options we have, but I don't want to promote laboratory tests. What you can do is an early antigen, which is really, really important. Early antigen for Epstein-Barr virus, deactivations, persistencies, this is really important, EA it's named. And what you can do, the lytic antigen in the interferon gamma release assay, which is named quantiferon in this direction, cellular test, ELISpot test, ELISA, whatever test could do that, a lytic replication marker. It's really a good marker, in my opinion, of the cellular activity of Epstein-Barr virus. Here are a lot of studies about breast cancer and EBV. You can get these slides. Also, you could get this presentation from Eva Sapi. It's also, I think, on the AONM website, so that you get the Bartonella and the Borrelli. She also discussed Bartonella and breast cancer associations. So you find a lot of studies about that. The more you do research, PubMed listed paperwork, the more you will find for sure. But a lot of these papers are completely unknown in the world of the oncologists, or I don't know, they don't check this simply, or they are not in the guidelines of chemotherapies, of differentials. So this is really important also for you. If you're interested, if you're a medical professional, please inform yourself, because you will not get a support from most of the oncologists, I'm sure. In 2019 came a review. The increased expression of cytomegalovirus, the correct word is human cytomegalovirus, HCMV, gene products found to correlate with a more aggressive breast cancer, BC means breast cancer phenotype. Also in this, cytomegalovirus is part of the herpes virus group, which plays a really important role in the world, also in the Lyme group, also in these opportunistic infections, also in long COVID, post-COVID. But today the chapter is about the breast cancer, or cancer in general, HCMV. The expression was evident in neoplastic breast epithelium in a high percentage in this paper. And so they found in over 90% of the tumors, this is really interesting, to check. I don't know if there's some pathologist among us tonight. So we need the pathologist doing PCR, as an example, from the tissue. The same I postulate in Lyme and other infections. We need to check with a good PCR technique if we find some viruses in this tissue where you have cancer cells in it. Normally, the histopathologists or pathologists don't do that. This is a chapter which is really, really important to do a multiplex PCR, as an example, on these biopsies to check them for different viruses, maybe also different pathogens like Borrelia, Bartonella. And if you can prove that directly in this cancer tissue, yeah, maybe it's not just associated, it could be the reason for it. Mycoplasma was also found in positive in among 40% of breast cancer cases, 2001 study. Mycoplasma is also, as you can see in this overview, also associated with esophagus carcinoma, pulmonary cancer, lung cancer, glioblastoma. So also in this kind of, in fact, cancer, we also can find an association again with mycoplasma infections. Mycoplasma is normally aerogen transmitted infection, but mycoplasma bacteria can be transported intracellular with macrophages everywhere in your body and in fact inflame parts of your body. This is where Eva Sapi talked about 2 weeks ago. Bartonella infected breast cancer could be also a reason in the endothelial cells. Also a paperwork just from Eva Sabi. This was a clinical paper in 2012. So this idea from Eva Sabi is nothing new. She's doing basic research fantastically. But they found also in cancer patients, breast cancer patients, an association with Bartonella. Bartonella, maybe not everybody knows. It's a easy word. It's cat scratch disease, Bartonella henselae. So the next point, ask all of your patients with breast cancer for cat scratches or maybe for tick bites, because it's also on the ticks, Bartonella henselae. It's a lymphotropic pathogen, also likes the liver, can do neuropsychiatric symptoms, this Bartonella henselae infection, but it has to do with cats. And this, it's transmitted under the nails. Yeah, if you got scratch, and some of you know the stria, this red stretch marks on your body. So inspect your patients for that, also with breast cancer. There's a lot of research going on in this Bartonella field, also in America, with Dr. Breitschwert, a really good scientist. So let's see what's going on with the cats. And the reason for this infection could be really in the past. So I ask all of my patients for cat scratches, contact when they, during childhood or so. So ask the cat anamnesis. It's really important. All the tick bites could play also a role. So now coming to the blood cancers. This is really very interesting with lymphoma. You heard about Burkitt's lymphoma. You all know about Hodgkin's and the non-Hodgkin's. Mantle cell lymphoma, which is really bad lymphoma. B-cellular lymphoma, this dominant lymphoma, the non-Hodgkin lymphoma we have over years now. Myelodysplastic syndromes, leukemia. The acute lymphoblastic and chronic, the ALLL and CLLL. There's a differentiation we learned all at universities, being medical doctors. And this is really interesting with the Epstein-Barr virus, which is one of my favorite viruses, also long COVID. Reactivation with myalgic encephalitis, this fatigue the patient suffering from. It's a link exists from Burkitt, the Burkitt lymphoma, since the 50s. So it's a very old thing, 70 years old, nearly 1 century. And he found the first association of this Burkitt lymphoma, which became later on famous in the HIV patients group. Some of you know this history in the 80s. Burkitt lymphoma, what is it? Burkitt lymphoma, we learned about that in HIV, but the association with Epstein-Barr virus was given from this scientist Burkitt. Epstein-Barr virus, coming back again, is associated with various human hematological neoplasias. It's tumorigenic herpes virus of the herpes virus group, and it cannot do just the Burkitt lymphoma. It's also described in the association with Hodgkin's disease and the post-transplantation lymphoproliferative disease. Abbreviation is PTLD. I never have seen such patients, but if you do transplantation medicine, you surely will or you should know about that. In England, that was your work, a professor in Sussex at university some years ago. He found now the mechanism. Professor West was his name. He found a key step towards uncovering how this common virus, which affects thousands of people with this Epstein-Barr virus, every year causes blood cancer. He said, this professor causes blood cancer. Okay, he's a professor. I'm not a professor, but he said this word. He's a clinician and a scientist. He said this word, so he said that's a reason, that's a cause. Okay, he didn't say it's an association like I now saying that. But this was really pioneer work. He found out the reason why it's changing the cellular structure into this promoter hubs where now this cancerogenous potential of Epstein-Barr virus is coming out. And maybe I go back to my career in oncology. I tell you that story. 1993, I had a patient with mononucleosis. with a very fresh 19 years old patient came to my clinic. I was infectious disease doctor responsible for that, and she came with swollen lymph nodes around her neck and here everywhere swollen lymph nodes in the ankles. And I said, oh wow, maybe, because I was the same time at oncology, I said maybe, oh wow, this could be a cancer, a lymphoma. Okay, in the differential blood count, it's really difficult. Sometimes you have some specific EBV cells in that to differentiate that. And we had the problems that time. It was also leukocytosis. I think there was also something bacterial going on, leukocytosis, lymphocytosis, maybe atypical lymphocytes. And we did a biopsy. That time I did a biopsy from her lymph nodes, and we sent that in Germany. It was named the 𝐃𝐈𝐒 classification. That time they did a classification. We sent the biopsy there, and then my boss, my CEO, my oncological boss came to me. He was on holidays, and he said, "Oh, why did you do that? I think this is mononucleosis. This is a very fresh EBV infection." And I was really shocked. I said, "Oh, now you did a mistake. Why did you do this? Why did you do this? I mean, that was a mistake in your career." Yes, in the end, it was no mistake. She really suffered from a very fresh Epstein-Barr EBV infection. He had a swollen liver, a swollen spleen, so everything was clear afterwards. The transaminases corresponding high, elevated. But then this 𝐃𝐈𝐒 classification came back. They needed some weeks, months. It was really a non-Hodgkin lymphoma at the same time. So a very rapid progression into non-Hodgkin lymphoma. That was my first case with a non-Hodgkin lymphoma and Epstein-Barr virus. I remember exactly. I was so astonished, but I said, okay, this is maybe a single case. We didn't have the internet research. It was not possible that time, but I could tell you that was my first case. And so that was really important to do this, this process with the biopsy to rescue maybe a life. Not getting later very acute an ALL lymphocytic leukemia. So she had both at the same time, very rapid progression from that. Patients with Hodgkin's disease have greatly increased cells with also HHV6 DNA. HHV6 is really getting famous in multiple sclerosis, also in the post-COVID now. In this discussion, it belongs also to the herpes virus group, a human herpes virus group. It's the 6th virus. Exanthema subitum, it's named, but it could be also getting reactivated, also in HIV patients, we know that. But we know that patients with Hodgkin's disease frequently showed elevated serum titers against this HHV6, and their tissues have increased numbers of cells. We can do also PCR in the blood, but we have also the really great ELISpot test, cellular activity test against this virus. And I think it's very common virus in fatigue or in England, myalgic encephalomyelitis and also Hodgkin's disease. We need to differentiate that, and we need to find association or not. Also the mantle cell lymphoma, the non-Hodgkin's mantle cell lymphoma are not, they are really rare, but Hodgkin's, I also treated some Hodgkin's and non-Hodgkin's, but the association could be also with Borrelia infections. Borrelia burgdorferi, also we had a study 2008 where Eva Sapi had seen this, and she is doing now some basic research. They said 14 years ago, our observations suggest the previously unreported association between Borrelia burgdorferi infection and risk of mantle cell lymphoma. It's a really rare lymphoma we can see. Moreover, they said the regression of lymphomas upon treatment of the Borrelia infection has also been reported. So if you treat this Borrelia, maybe you have a chance to treat the mantle cell lymphoma if you're not coming too late, if it's not everywhere with metastasis in your body, and you have some chances with it to make it reversible. So there's an association, and they said also maybe it's a reason we can treat this with antibiotics or so, and then the tumor progression is stopped or is going back. Babesia is tick-borne illness, also malaria-like illness. It's also in blood transfusions. You could get this. It's malaria-like, and it has association with B-cell lymphoma. And in this study from 2008, they found the majority of patients with babesiosis had underlying B-cell lymphoma. The question is again, is it Ly-Sin-free? If you treat the B-cell lymphoma with chemotherapies, you suppress the immune system. What happens with babesia? That is really a key question. Or should you treat this both at the same time, the babesia with anti-malarial, and you treat also with chemotherapies, or you treat first babesia and then you treat this B-cell lymphoma? Every case is a little different and needs your individual decision, oncological decision. Ehrlichia anaplasma is also a really important infection in Europe. It makes musculoskeletal symptoms, dominantly rheumatoid arthritis as an example, but it's also associated with myelodysplastic disease and leukemia. EA is the abbreviation for Ehrlichia anaplasma. All of these pathogens, maybe to mention, are intracellular. Not any of these pathogens is extracellular. So Borrelia is the only one of these viruses are all also strongly intracellular. You know that they use our mitochondria, mitochondriopathies, fatigue. All of these patients have this. So they found also this intracellular Ehrlichia anaplasma infections. They suggested in this paper a direct effects on the immune system, for sure. Inflammation coming, immune dysfunction coming from infections, consistent with the manifestation of leukemia. And also they hypothesized, moreover, that treatment of leukemia with antibiotics effective against this Ehrlichia anaplasma infections could have a result or has a result in beneficial benefit for the patient and beneficial impact. This, they tried it, but in the end, the patient died because there was a strong progression in the end. Coxiella, it's a tick-borne illness. It's inhalation. It came from the sheep also. You can inhale it outside. It makes a lymphadenitis. It could lead to lymphogenesis and then to the non-Hodgkin lymphoma. We have also paperwork about that. It's also intracellular. It's persistent in the macrophages. It's Coxiella burnetii, if you want to learn about that. Burnetii, if you want to Google for that. And we know that this is really associated with non-Hodgkin lymphoma, which is the most common lymphoma percentage in the world. So it's coming from cows, sheep, and goats. I mentioned just the sheep, sorry about that. It's also in unpasteurized milk from sheep. You can drink it and you can get infected with it. So pasteurized milk is better than unpasteurized, not to get this. On the right side, you find the overexpression of several genes. I'm not the expert for this, but if you're interested, you can go into the paper if you have more knowledge than I. It's named the Q fever. That's also important for you. Lymphotropic, lymphomagenesis, non-Hodgkin lymphoma, very, very close together. You also have problems for sure with detox. You have problems with these patients. The lymphatic system is swollen. They cannot transport the rest of the dirt in our body back for detox processes. Children treated for acute leukemia at risk of severe varicella zoster virus. So coming back again to long COVID, also varicella zoster virus plays a very important role in this. You heard about that. It's a lymphotropic virus for the CD4 helper cells and CD8 suppressor cells, and it induces the production of cytotoxic T cells, and that recognize and destroy virus-infected cells. So this suppresses your immune system. Therefore, we are doing the CD3 cells in some panels. Varicella is really a lymphotropic virus, and everybody who had varicella zoster or herpes zoster infection or reactivation who knows where I'm talking about that. So in children, it plays also a role in the chickenpox story. Chronic lymphocytic leukemia is highly sensitive to infection by herpes simplex virus 1. This is also really interesting, this study from 1999. So we know that CLL, chronic lymphocytic leukemia, could be also associated, again, not recent, associated with herpes simplex virus 1. Nowadays, I think also herpes simplex virus 2, because we find more also in the respiratory tract in the blisters with subtype 2, so, and also one in the genital tract, but there's a masquerade. Masquerade is a good word. Chronic lymphocytic leukemia. A masquerade. What is a masquerade? It's mimicking masquerade. So what does that mean? That means if you diagnose a patient with herpes simplex virus 1 active infection with an IgA, which is most important, and maybe ELISpot test, then you maybe treat this herpes simplex virus, and maybe you have a chance to improve the patient from that, from the lymphotropism of this virus, to bring it back into a sleeping phase, into a latent phase, not an activity phase. That will help a patient, but also should help immune dysfunction to support the immune system. The next is the monoclonal gammopathy, MGUS. I think you know what it is. I don't need to talk about monoclonal gammopathies. The IgG is the dominant one, the kappa lambda chain. You need to do that. It can destroy the bone marrow for sure. It can be everywhere. And if you have a polyclonal stimulation, this also you need to know in an infection. This could mean that this polyclonal stimulation of IgG or IgM can develop a clone, a high specific clone, which could be transformed into monoclonal gammopathy. And this is what is happening with Bartonella infection. In this case, it was Bartonella quintana, which is in the ticks as an example. It's not the cat scratch, not the Henseley subtype. We have also a lot of these Bartonella subtypes. And they treated this patient, interestingly, with this gammopathy, with a bad thing, nearly dying a patient, with 8 months of antibiotics. So long-term antibiotics rescued the life of this patient. I don't have so many studies about monoclonal gammopathies. We need to go more into that. Glioblastoma, I think it's really interesting. Also a type of cancer, more and more patients getting this, also younger patients. We know that L. McDonald, which is really a great professor in America, he found the first association of Borrelia burgdorferi in glioblastoma multiforme. He did a fish DNA that time. A lot of these studies or work were not published. They were simply suppressed that time. They didn't allow him to publish that, but he found an association. And if you talk with him, he's a pathologist, really a very, very knowledgeable pathologist in this field. Also, 𝐕𝐈 is now coming to that more and more. In glioblastoma patients, cytomegalovirus, we had this virus before in the breast cancer. The activity is higher than in healthy controls. This is also a link, a sign maybe that there's an evidence of cytomegalovirus. It's in 90 to 100%. I think that's a lot. The question is how these guys, scientists, diagnosed that in the paperwork, if they did an IgG or IgM test, or if they did an ELISpot, lytic antigen, if they did a PCR on that. The question is, the studies are so good, the analysis you're doing in scientific laboratories, but they found that human cytomegalovirus could modulate the malignant phenotype in glioblastomas by interacting with key signaling pathways. That means if you have a cytomegalovirus infection active, I would treat this independently if you have a glioblastoma, if it's possible from oncology side. Glioblastoma toxoplasmosis, also really interesting. Toxoplasma is an infection from the cats. You know that eating also meat. So if you're pregnant, you should not have a cat contact or eat meat. You see it, life cycle on the right side. In this paper, 2020, very new paper, they found the first perspective evidence of an association between Toxoplasma gondii, it's named gondii, you say in England in English, infection and risk of glioma. So it's a parasite. So you also use some antiparasitals in this therapy. Also some antibiotics are used. That it's these patients with an active Toxoplasma infection that they have a higher risk to develop glioblastoma later on. So they always say further research is needed, but as we all know, money is not so there in this field, and we need more papers. Everybody's telling we need more science on it, but let us do the science and find it out. Toxoplasma gondii inhibits the glioblastoma apoptosis by touching a purinergic signaling pathway. This finding came in 2019. Also, the word masquerade is coming in this paperwork. It's a masquerade toxoplasma. So if you have toxoplasmosis active in a patient, treat this parallel to cancer treatment. The question, if you can do that at the same time with, as an example, antibiotics, which are also like chemotherapy, like you need really to have a strong immune system for doing chemotherapies plus or radiation or surgery together with this toxoplasma infection. Mycoplasma, you heard of that before. So mycoplasma infections play also an important role in glioblastoma. Mycoplasma infections have been found in different types of carcinoma tissues, including glioma. We found that already. We saw that in the former paperwork with also different breast cancer. There are different pathways, and in every paper you read the word inflammation. We have also in infection inflammation. We have also in cancer inflammatory pathways. We have coagulopathy problems. So it's always very similar, the stories. And the cytokines play also a role in the damage, because mycoplasma is also doing interferon gamma release as an example. So the cytokines can also damage and could lead to inflammatory lesions in glioblastoma. The last type of cancer I want to discuss tonight is a prostate cancer. Prostate cancer is really a cancer which a lot of men suffering from when they're getting older. And in 2011 came a study about Mycoplasma hominis. To be honest, we don't have a good test for that. Let me think, the ELISA, we have a fermentance test and a TICPLEX, but not a hominis test. So we need in routine laboratories a really good certified hominis test to find association with a prostate cancer as an example. So if you ask me, Armin, could you do a blood test? I cannot do a blood test. We don't have this test. Chlamydia pneumonia, yes, we have this test. We can check an IgA and the ELISpot corresponding. 100% of the prostate biopsies were positive, 10 patients demonstrating the presence of this microorganism inside the prostate gland, both in prostatitis, hypoplasia, and prostate cancer patients. So we have a high association of chlamydia pneumonia, which is a pathogen in your lung. It's not primarily, but then it's transported by macrophages everywhere around your body, doing inflammation, infection process, immune dysfunction. And this is really very close together. In 2013, there was a meta-analysis showed that herpes simplex type 2 is associated also with elevated prostate cancer risk. There was a really high association with it. And they said also preceding herpes zoster, varicella zoster infections could be also a risk marker for prostate cancer after controlling potential confounders. So they suggest also in a paper that herpes zoster could be in an early manifestation of immune impairment, that it could be associated with occult malignancy. So that means that if you have herpes zoster actively going in your body without having these blisters or this pain outside, it could be also inside. your immune system working. We see that with many patients. It's also doing arteritis, atherosclerosis. A lot of the strokes patient, heart attacks patient are associated with herpes zoster. So herpes zoster also in post-COVID, please don't underestimate herpes zoster infections. We have a lot of evidence that it's doing a lot of damages and also this tumor cells, and it has also escape mechanisms to evade the immune system, so also difficult to treat. If you say, now I give a virostatics, ganciclovir, valaciclovir, it's not so easy to treat. The virostatics cannot, they can reduce the viral load, but cannot destroy it really. You can bring it maybe into a sleeping phase, to immune control phase, strengthen the immune system. I think it's a better thing than stress the immune system and using corticosteroids as an example. So coming now to the end, so we have enough time for discussion. We will do further presentations, or we did them already in 2017. We started with it. Tick-borne disease and viruses in cancer and unexplained syndromes. We were focused on the tick-borne parts and the viruses. That time that was the first trial. And now it's more and more evidence. 2018, we did an update, an upgrade with this, with AONM. And this, I think, is also really important now. Which test could we do, or which pathogen could we check in breast cancer? As I mentioned, Borrelia burgdorferi could play a role, association with it, Epstein-Barr virus association, cytomegalovirus associated, mycoplasma associated, Bartonella associated. In blood cancers, we have a longer list: Epstein-Barr virus, 𝐻HV6, Ehrlichia, anaplasma, Borrelia, cytomegalovirus, Coxiella, the Q fever, varicella zoster virus, herpes simplex virus 1. This is all evidence-based paperwork I showed you. This is nothing hypothetical. Monoclonal gammopathy, we have just Bartonella, which we can demonstrate, show you. Brain cancer, we have a little more, Borrelia burgdorferi to check, cytomegalovirus, toxoplasma, mycoplasma, prostate cancer, also mycoplasma, chlamydia pneumonia. Mycoplasma, we don't have a test, as I mentioned, for that. Herpes simplex virus 2. So which tests to use? I'm a fan of the IgA test, if you know myself, and I'm a fan of the cellular analytics, so the interferon gamma release assays. These two will play the key role. In EBV, you have the early antigen, don't forget this. For Borrelia, you could do the ELISpot, and we don't have an IgA, this is not so good. We needed Epstein-Barr virus with the early antigen, we have the ELISpot, the lytic antigen. For cytomegalovirus, we don't have an early antigen, we have a lytic antigen in the ELISpot, really great test. Mycoplasma, we have fantastic IgA, ELISpot, Bartonella, we don't have an IgA for the local infection, inflammation. We have the ELISpot for that. Blood cancers, the same, 𝐻HV6, ELISpot, IgM antibodies, PCR helpful. Babesia, we have an ELISpot, antibodies are not so helpful. Anaplasma, the same, ELISpot. Coxiella, unfortunately, we don't have a cellular test. I talked today with a company from London with a cellular test, or from England. I said we need a Coxiella parasital test, also more for toxoplasma. Oh, wow, interesting. Hopefully they will develop some cellular tests for Th1 immune reactions against these pathogens. Varicella zoster, the IgA I would prefer. The ELISpot is not so strongly reacting. Herpes simplex virus 1, do the IgA test. Bartonella, ELISpot, Borrelia, we talked about. Toxoplasma, we just have IgM. Today I validated one IgM report from a clinic, so IgM positive report, so very important. Mycoplasma, IgA, so we don't have so many tests. We need to fill up these profiles. Yeah, and I will let you know that the second part we will do on the 6th of September, if you're interested. So we said now it's a summer break. We all need a little relaxation. And we will talk then about the connection between infection and cancer. The part 2, lung cancer, colorectal cancer, gastric cancer, a very interesting field, esophageal cancer, cervical cancer. So maybe we will do the list longer. Yeah, and then I come to the end. Thank you very much for your attention.
Thank you very much, Dr. Schwarzbach. Absolutely fascinating, and a lot of new information there. There have been questions about the types of testing that you recommend, especially for viruses, and I think you have just gone over that, but perhaps you could explain in a bit more detail for those who are not so familiar with the different, for example, immunoglobulins, why you emphasize the IgA so much over the IgM and IgG to start with.
Yeah, we have a presentation done, Gillian, also about IgA, how important it is in reactivations. The problem is IgG cannot tell you, is it reactivated? The only except IgG means a pass infection without IgM, without IgA. IgA and IgM is a very fresh antibody infection, or can be also reactivated, also in herpes simplex, also in cytomegalovirus infections, also Epstein-Barr virus. You can find IgM with if you get a reinfection or a chronic persistency, or if you get reactivation, opportunistic infection, then the IgM could go up, but the shortest half-life time in this local infections is the only marker we have, the IgA. IgA is the only expression locally antibody production. The IgM is just systemically produced in the very fresh phase or in the systemic phase, also in systemic reactivations when you have very bad infections. And the IgG, yeah, this is a marker. We all have a lot of IgGs, the IgG can a titer development can tell you if it's reactivated or not. So one IgG point you detect cannot tell you, is it reactivated? You need a second message 2 or 3 weeks later to compare the titers. And if you have a doubling or 3-fold, 4-fold titer, this could also be a reactivation. The IgA has a very short half-life time of 7-10 days. So it makes it really, really interesting marker. So the way is going chlamydia, mycoplasma in Germany, as an example, we don't do IgM, also in hospitals, in the very fresh infection, because they're all locally producing this IgA, this infection. Also, Borrelia is not a systemic infection. It's not septical, It could be for a short time a septical process. The IgA is, I think, very interesting. And regarding the cellular tests, yes, really good if you have a lytic antigen for a replication marker. So the people ask me, what does it mean, lytic? Lytic means active replication of viruses, not sleeping, not snoring. Snoring means the latent phase, latency. And we could really very well differentiate that.
Though I think you have also explained in that slide about Sussex University that the latent form, especially of EBV, can also be of importance in the development, or at least association with cancer.
From herpes simplex of the lips that it could be reactivated, or varicella zoster virus. They are sleeping, snoring. The question I discussed also the last days with patients and doctors, could it be that you get rid of this virus from your body? Could I eliminate the virus? Can I eliminate a pathogen? Can I eliminate SARS-CoV-2 protein rests in my gut? Can I eliminate this? Because we find it also in the stool, this virus particles. It's not active that time. It's a past. But the question is really, could we eliminate? I think we live with a lot of viruses. We control them. We say, you are my friends, or the virus is such aggressive. I showed that one case that it can immediately bring you into transformation, changes, alteration of your DNA, and then you come into a cancer. So we need to be careful with all of that in this reactivation phase. And it's deep inside your body, it's not outside. If it's coming outside, it's really, it hurts here, it hurts there in the lips, the blisters or genital herpes. But what we need to care is what happens in the lymphatic system, what happens in the liver, what happens in our bone marrow, what happens in our brain, in the tissue inside, because they persist there and they are snoring there, or they are active there.
Thank you. Yes, we lost you just for a tiny minute there. Just to address a couple of questions that have come in. The Armin Labs tests can be obtained in the UK through AONM. That's the Academy of Nutritional Medicine. That's the website aonm.org, and there's a lot of documentation up there under the tab. But you can always just call the helpline, and there are a lot of different past webinars, including the ones that Armin has just pointed out to us that are available on the website. One participant is asking, Armin, whether your tests will be available in the USA again.
In 3 weeks.
When they will be?
In 3 weeks. Yeah.
Oh, fantastic. Okay.
2-3 weeks it will be coming there. Yeah. Revival band. Creedence Clearwater Revival. What I want to mention, I think AONM, I decided also to cooperate with you because you do the circulating cancer cells. And this is really important thing. Not many people know about that test. There's Professor Pachmann, a really good scientist in Germany for years. I worked with my former laboratory group, which was together with her and her husband, Professor Pachmann, for coagulation. He's really a good professor. And they offer the circulating tumor cells. This is really important because everybody from us, we have some bad cells, circulating cancer cells, and we eliminate them. It's in a steady state, and Pachmann, not just to promote her, but I think this is really important test if you have a cancer to check this also.
Yeah, thank you for mentioning that. And they actually said they're doing a related study right now. So I think we'll bring them on perhaps together with you. That will be extremely interesting. One participant here mentions that her brother has a rare cancer, myelofibrosis, secondary to polymorphism. Could Lyme be connected to this somehow? Because there is a history of that in the family.
I don't know a study about that. We should check for a case report, maybe if it's written as a case report. I would not exclude that because as you have seen in glioblastoma or other types of cancer, sure, all pathogens can do that. So if a patient has Lyme symptoms, not just this fibro symptoms, but we know that also Borrelia does a lot of fibromyalgia associations, not just rheumatoid arthritis. So why not checking that? And if you find it active, I would do a trial to treat this and to give a chance. Maybe it's also a new chapter and we could write a new case report about that.
Yeah, maybe the attendee could send in his or her details to AONM and we could then follow that up, both looking through the literature for connections as you've just suggested, and also, if appropriate, suggesting tests. So please do that. Another has asked here, you mentioned cellular activity and testing that, but which particular test is it that would test for the cellular activity?
Cellular activity. Yeah, this is for the viruses. It's named interferon gamma release, which is the main cytokine of a active cellular immune response. Interleukin-2 as an example, or 6, or 10, or 17, or whatever, 12. These are Th2 system, then if you have a past infection. So we are doing the interferon gamma release assays. And as we do also in COVID or past vaccinations, also it's a helpful test for immune reactions. Don't say immunity in this case. So this is a helpful test, the interferon gamma release assay for different pathogens. And I really would mention the EBV, Epstein-Barr virus, ELISpot, and the CMV ELISpot. It's so fantastic because we can differentiate lytic antigen. If you don't know what it is, go to Wikipedia, everything's nicely explained. And you can differentiate between the lytic and the latent phase. And this is a test which is a key play in transplantation medicine. It's highly recommended there. So it's not a hocus pocus antigen test or what we are doing there. Also, we're just using it for infections and also maybe to find an association with active Epstein-Barr virus infections or cytomegalovirus virus. The lytic antigen is so important. Yeah.
Thank you. That's very useful. One doctor colleague here asks, are there any clinical trials which identify the associated infection, treat with the appropriate antimicrobial, and demonstrate tumor regression?
Yeah, I showed in 2 slides. It was this, you need to help me. It was in the beginning one case of this Ehrlichia anaplasma with this lymphoma. It was stopped and a good outcome. In the end, the progression was too hard. We had this Bartonella case. There was also one case in England, if we didn't show tonight, where one Bartonella breast cancer patient in England get a breast surgery, amputation, both breasts away, chemotherapy. In the end, it was a Bartonella infection. They treated successfully the breast cancer, so-called, because it's so close for the histopathologist, successfully, and it was completely reversible. We didn't show that case, but you will find it for sure.
Yeah, we could emphasize more of those the next time around. And another question here, do you find oncologists are willing to acknowledge underlying pathogens in their patients?
Yes, we have in Germany a huge group. It's, as an example, we have the hyperthermia group in Berlin, where I'm going, also Charité in Berlin. They're doing a lot of hyperthermia with these patients successfully, also local hyperthermia, generalized hyperthermia, a lot of hyperthermia going on, also Munich universities. And they named the group biological cancer medicine. That's a huge group. And we have another group, it's Landenberger group in Munich. Also, all of these experts, I did also presentations in German language, and they are not all oncologists. There are some oncologists also. I don't want to do marketing now. There's a clinic here, not far away from Munich. They are treating these patients with cancer, with biological treatment, high dose vitamin C or whatever. They're using hypothermia, but also chemotherapies. They are oncologists, and they are checking also for infections for sure, also for Borrelia and other pathogens. Yes.
Yeah, that's maybe another area that we could cover.
But it's a minority. It's not the guideline. Okay, this is minority.
It's more extensive, I believe, in Germany than here in the UK.
Yeah. In Germany, there are different clinics for that. Yes. Yeah.
Another question here from a therapist. I noticed that Coxsackie virus hasn't figured tonight, yet I pick it up in 100% of my patients doing lab tests. Can you comment on any association with cancer?
That's a good question. We didn't find so many papers.
No. We can do a further.
We need to check that. Yeah, that's very interesting. We know that it's doing autoimmune disorders, juvenile diabetes, Hashimoto's, whatever, ANA titers, collagenoses. There's a high association with this transformation, but with cancer. That's really a good question. We need to answer enteroviruses if they really are associated with cancer. I don't know.
Yeah. Well, we can maybe have a small focus on that next time. Another here mentions that she believes 𝐃𝐈𝐒𝐿 is also associated with prostate cancer. Would you back that up?
Yes. I saw a case report about that. Yes, we could not bring all of that. We need also to fill it up for sure. And Gillian is also helping me with some ideas there for the next presentation. We
maybe need to do a third presentation, particularly here. There's another entirely different sort of field, which is, are fungal infections implicated in associations with cancer? We haven't covered that at all, really.
And more checking for parasites, Toxocara canis as an example. It's very important with the dogs, this infection, and we need to do more PubMed research for that.
But specifically fungal infections, is that something you've encountered in your career as well?
This is a chapter we don't have so many good tests, to be honest, and nobody's caring so pretty much. They are all focused on viruses now, because of Corona, they're all viruses. Lyme disease, co-infections. But sure, this is a chapter, yeast and mold for sure.
Yeah, needs looking.
We should also check this. Very important. Yeah.
Will do. Okay. And then it sounds as though IgA is appropriate for biopsy tissue in particular, one doctor mentions here. Would you agree with that?
Yes, absolutely. I'm a fan of the IgA in the blood. It's produced from the tissue, so you will find it in high concentration. The secretory IgA in stool, as an example, or you find it also in the tissue. So these antibodies, transglutaminase, also produced there. So the question is the infection associated again. with a celiac disease. We did also some presentations. You remember dealing with autoimmune disorders, which is my second specialty. But this cancer, yeah, absolutely. The IgA, it's important in the tissue. If you have I'm not doing that in the tissue. I'm not a pathologist.
Yeah. Another colleague here asks, do you think that cancer predisposes patients to catching infections, or is it the other way around?
Hen and egg question. Yeah, sure, it could be the other way around. But if you have a cancer, you have also a bad immune system. Okay, it weakens your immune system. The cancer cells always, after a while, you get a bad immune system. And if you treat it, the chemotherapies are massively immune destruction. That's clear. Antibiotics are massively immune destruction. They belong to chemotherapy group. So you destroy cellular immune system, the CD3, CD4. So there's surely a predisposition if you have a bad immune system. HIV patient, that's a typical example, the Burkitt lymphoma. Why does this happen? Because EBV is reactivated, the transformation from EBV into Burkitt lymphoma. So we have that proof with the immune system.
Yeah. Another question relating to fungi and cancer. I've just been going through these sequentially. I'll read it in detail because it's a bit longer. There is evidence of symbiotic infection between microorganisms through their biofilms, such as bacterial and fungal pathogens. Have you found evidence of an association with cancer and fungal pathogens such as Aspergillus or Candida species?
Yeah, the Aspergillus can do that. Yes, I know that. In the pulmonal system, aspergillosis. It's really a tragedy for the patients who have that. The question with this biofilms, I asked Eva last time, how can you prove a biofilm in this? You know, it's we don't have a test for biofilms. In the culture, yes, but not in the humans. We need also this biopsy to check for biofilms. So with this Aspergillus, I think it has also a cancerogenous potential, because every infection which is in you has this potential for sure.
Thank you. And linked to that was the question, do you have tests for identifying fungal species, such as Aspergillus or Candida, which were
yes, we
mentioned
have one Aspergillus antibody, IgG, IgA, IgM, and we have the ELISpot for that. That's all. But the whole world of this mold is not just the Aspergillus world. You know, we have a lot of different other subspecies and species there.
Yeah, Candida was also asked about.
Candida, you have also tests. These are the most common, but this is exactly the question. I talked today with this guy from this cellular company from England. I said to him, yes, we need tests for that, for yeast and mold. We are restricted, and in accredited laboratories like mine, we are just allowed doing certified tests, IVD registered tests according our high quality. We cannot do in-house home brew tests. You know, it's not allowed. So we need external control mechanisms. It's so strongly controlled in Germany, you cannot imagine how our authorities control our tests. And the test producers, you buy this test from certified test producers. We need more energy in this. So I try to motivate as I can, but it's difficult. We don't have so many tests on the market.
Yeah. Another doctor asks here, how can we ever keep track of all these viruses that we carry around? Should we do regular tests or just when it becomes a problem?
This is the patients, it's always the same. You come because you have a symptom, and then you start with the test. Oh, I have meanwhile long COVID. I have a cancer, breast cancer. Should I test now for Bartonella? This is a question of prophylactic testing. What are the consequences for that? How do you feel? Does it have really consequences? Should you treat an asymptomatic patient? It's the same if you do tumor marker antigens in healthy people and you find a positive tumor marker antigen. What do you do then? Do you use a chemotherapy or do you breast amputation? What do you do with these people? The more you know, maybe the better. The less you know, also the better for you not to have consequences and to have a good sleep. I think it's much better to have a strong immune system. To have a good lifestyle for sure, to have good genetics, to have not so much environment in you, and have good nutrition. The nutrition, microplastics, we didn't discuss that today. If you eat up plastics in your gut and it's in your body, what happens with that? Oncogenesis was also discussed at some points already. Now they left that way because everybody eats up plastics from the oceans, from the fish, and plastic, you eat it up, you drink it. So what aluminum, all of this discussion, we should not be just focused on this infections field. It's a multi-systemic problem, also genetic problem. We cannot change our genetic system.
You always say it's peeling the onion, isn't it?
Peeling the onion, yeah, your model you did some years ago.
One last question before we go, though I don't think this is so much a question as one therapist asks here, could you please repeat the names of the tests? I think they're probably, because you've mentioned different tests for each type of cancer, it would be most helpful if you could perhaps identify exactly which, and we'll ask you to do that perhaps before we put this up on the web, before we put it up on the webinar link, which we will. Maybe we could.
I went
exactly
into it.
Whether it's 𝐕𝐈𝐃𝐄𝐄, exactly whether it's the 𝐕𝐈𝐃𝐄𝐄 or the antibody test that you recommend.
Can you see that? Can you see that slide?
Yes, but whether it's 𝐕𝐈𝐃𝐄𝐄 or the IgA or the IgG, I think that's something we can definitely do before we put it up, isn't it?
Yeah, as an example, I was a little fast in that. It's my daily work. So sorry to be too fast. Borrelia, I would do an 𝐕𝐈𝐃 for sure. Yeah, if you want to spare money, that's it. The interferon gamma release, if it's cellular activity or not. Antibodies, maybe you could do a TICPlex basic for persistiforms. You could do CD57, CD3 cells. It's most important marker to get a general impression about our cellular and humoral immune system, the natural killer cells. So for Borrelia, I would say the 𝐕𝐈𝐃 is the first test, first line test, maybe TICPlex basic and the CD7 cells. For Epstein-Barr virus, we have good situation with the early antigen antibodies, early antigen EA antibodies. Ask your laboratory for that, really important. All of the studies are based on that for long COVID reactivations and multiple sclerosis, as an example. Cancer, they did the early antigen. We have the lytic antigen in the 𝐕𝐈𝐃, EBV 𝐕𝐈𝐃, a really important test for that. These are two, I would do both. For cytomegalovirus, we have no early antigen, no IgA, we have just the 𝐕𝐈𝐃, but we have the lytic antigen, so do the CMV 𝐕𝐈𝐃. For mycoplasma, we are in a lucky situation. We have the mycoplasma IgA plus the 𝐕𝐈𝐃. If you just say, I do the IgA, you miss the cellular immune responses, cellular immune reactions, interferon gamma against this. So do both. For Bartonella, I would just do the 𝐕𝐈𝐃. The IgG, IgM are not so sensitive and not so helpful. For blood cancers, I discussed already EBV. For HHV6 to the 𝐕𝐈𝐃 primarily, Ehrlichia, Anaplasma to the 𝐕𝐈𝐃, Borrelia I talked about already, CMV I talked about, Coxiella, Babesia, sorry, we have the 𝐕𝐈𝐃 again, Coxiella, we don't have a 𝐕𝐈𝐃, we have IgG, IgM antibodies, unfortunately. Varicella zoster virus do the IgA test. This is really important. Herpes simplex virus do the IgA test. For Bartonella, we talked about that. Toxoplasma, brain cancer, IgG, IgM test. Not so helpful. We need a cellular test also there, or an IgA test. We had some years ago an IgA. They took it from the market. Prostate cancer, chlamydia, pneumonia, IgA, and the 𝐕𝐈𝐃, and that's it.
Thank you. Well, we'll populate that with what you've just mentioned before putting it up. This will go up. People have asked whether these slides will be shared, and the recording also on the website. And we will also send out the recording when we mention the date of the next part 2, which is on the 6th of September. So the notification of that will go out as well. So thank you very much, everybody, for taking part. It was wonderful of you to have spent this hour with us. And Dr. Schwarzbach, thank you so much for a fantastic webinar.
Gillian, thank you so much. I have one comment. I saw a lot of questions also not relating cancer now, but I want to help, and maybe these questions which were not answered now because of the time, maybe you could email me or to AONM.
Yes, that was, I'll mention, that was an anonymous attendee, so we don't have the.
So we want to help. It's all
we'd
confidential, free of any costs. It's free of any costs. Yeah.
If the email is sent to us in some form or another to AONM, then we will forward it to Dr. Schwarzbach. That's very kind of you. The reason why I didn't ask those questions was because some of them were not directly related to cancer.
Okay, yeah, exactly. I saw that. But we want also, because I mentioned also other conditions, and I think it belongs to a broad-ranged medical work we are doing.
Absolutely.
So thank you very much, Gillian. Yeah, let us do together part 2, and all attendees are heartily invited in September to join us again. Thank you very much.
Thank you very, very much. Thank you.
Bye-bye.
Bye.